Let's start. Hello, everyone, and welcome to the next edition of Practo Connect webinar. This is the 22nd edition of the Connect webinar, and I'm very happy to invite you for this very interesting session on digital future of ENT and gynecology. To speak on this very interesting topic, we have with us two speakers. First, I would like to introduce Dr. Lavanya Kiran. Hello, Dr. Lavanya.
Hello.
So, Dr. Lavanya is presently with the Cloudline Hospitals. She was earlier with Narayana Health. She is a gynecologist and a robotic surgeon, a TEDx speaker, an author of multiple chapters in gynecology textbooks. She's also the secretary of Karnataka Society for Assisted Reproduction. She's got multiple awards nationally and internationally. She's been invited by MIT and Harvard for medical innovation platforms, and also has a patent on medical devices. Today, she'll be talking on the future of gynecology. We also have with us Dr. Rajesh Bhardwaj, sir. Welcome, Dr. Rajesh. So it's a pleasure to have you again. Dr. Rajesh was my clinical tutor in college in AFMC. Dr. Rajesh has done his graduation and his post-graduation in ENT from Armed Forces Medical College, Pune. An army veteran with services in Jaffna, Siachen, and a number of borders. He's been very interested in telemedicine and the use of technology in ENT. He's an active member of Telemedicine Society of India, and he helps them frame the guidelines for the use of telemedicine in ENT. He'll be talking about the digital future of ENT. So, Dr. Rajesh Bhardwaj, pleasure. We'll be listening to you. First, I would like to invite Dr. Lavanya to speak on her topic. Please, Dr. Lavanya.
At the offset, I think I would like to thank Practo and especially Dr. Bhardwaj for bringing me onto this platform. Without any delay, I would like to share my screen, if you permit. Is my screen visible?
It says started screen sharing. Yeah, it's visible.
Okay. So we all know that a digital future is going to be here, and especially I think the COVID has proven it. Previously, digital was just centered around patient and customer experience areas like appointment and feedback. Now it's coming to digitalizing health records, prescriptions, and COVID, I think, has pushed teleconsultation, enabling remote as well as digital connectivity. Despite the COVID not or receding, I would say rather, the digital health and the telehealth will continue to stay strong and integrated to clinical services. Going forward, there will be two areas where digital use will have a significant impact. And I think one is going to be additional tools that will be strengthening the remote and digital health management, like monitoring devices, which will measure and send data over to the tool or the apps that will be receiving all these data. This will also eventually push information data to the doctors, who will be monitoring remotely and work on customer and patient management. Like you all agree of how important it is now on what a customer wants, and their feedback is very important. This trend will continue due to COVID induced behavior of staying away from the hospital. We use this already in our practice, and I'm sure most of you are using as well. And the other one will be the health analytics, where health tech companies today are creating algorithms that will predict based on the family history, patient parameter, who might have been on a more higher propensity to develop any of the risk factors that I'll be talking, be it the PPH or the delivery, preterms and diabetes in pregnancy, and any cancers that will be coming across, be it the cervical cancer or the breast cancer. This area is evolving, and soon solution will emerge. They will not remove the clinical or the clinician perspective or the diagnosis, but please remember, a clinician will always be there, and they will stay in the part of the AI, and they will be the one who will be assisting the progress of the AI, and their management outcomes and their behavior, and they're equally important. I think it's very important that the clinicians remember and not oppose the AI, because AI is going to stay here. It is just that how are we going to be compatible with this? And these are the two areas which I'll be speaking about. And I think that is where we see a significant investment as well, and tools coming up and solutions coming up into delivery services And on that basis, I've divided my talk today. I'll be touching upon on what an obstetrician would be looking for, and me as an obstetrician, what I would want, and what innovations do I want in gynecology, infertility, and some screening tools that we can talk about. When it comes to obstetrics or your daily routine OPD of a general OB clinician, we all want things to be moving fast, because I'm sure on an average, any gynecologist would say anywhere between 30 to 60 patients. And of course, we have extremes like 100, 110 in a bigger setups or the government setups. Even there, I'm sure the doctor wants to do their best and clear up the patients without missing a single information. And we are already moving ahead with the electronic medical records, which has been used in most of the places. But I request for all the people who are entrepreneurs here and investors and innovators to look at a doctor-friendly EMR. You need to realize most of the doctors are not very technically friendly. Of course, we have a lot of them picking up on these technical skills. And like I said, they are getting into AI and helping out. Even before you decide to do an app, don't start from what do you want to have. Always make sure a success of an app is going to be there only when you have a clinician in the team. You try to understand what a clinician wants, because their perspective of an EMR is different. And it definitely has to be patient friendly, because they're not going to be very good at typing or something like that. So simple things like text to speech could be a good thing, or speech to text is a good thing, where you speak and everything automatically comes. Or when the patient themselves are speaking, it can come in, and the patient initially, even before seeing, because there's a waiting hour definitely for any patient between 30 minutes to an hour or 2 hours, depending on the type of the OPD that you're dealing with. So where the patient themselves can write down the history, and the doctor can go through, like they're an hypothyroid, they've had a previous loss, or they've had a complication. What is their past history? How long are they married for? And what gravida is it? And what complaints have they come in? If the patient can come, and these things can be collaborated for the doctor to use, and while they continue to write their prescription or they use the EMR, they need to be integrated. And if already an EMR is existing in the hospital, and you have another innovator who has come up with a friendly EMR, and the doctor wants to use that, it needs to be important that both the systems speak to each other. And whenever there's a transit from one EMR to another EMR, please remember there's a lot of data loss which happens. And I've seen it myself in the institutes I've worked. And it's very important that your patient confidentiality is maintained, and the systems or the collaboration needs to be friendly with each other, where the data synchrony is going to be very easy for each other. So in this EMR, we expect that there should be a high risk alert which comes on to the doctor. Patient can send in the risk factors, and the doctor knows who needs to be seen on a priority basis in a busy OPD. And also a follow-up, I think, is very important. Sometimes the patient forgets when is their appointment, or the doctor wants to follow up a particular patient and the patient is not compliant in coming. I think there could be a small reminder for the doctor that this patient needs to be seen. Or if she's not ended up in the OPD, there is a beep which goes into the patient app and the doctor's app, where they're reminded that they need to be seen. So that means there should be an easy accessibility of the patient contact as well, which is just at a fingertips, which is very important. A regular text and information on the requirement of the information. So what does that mean? If I'm looking at a pregnant woman, I want them to have a lot of information, because what is a time consuming for a doctor? Counseling. Of course, counseling is a very important part, and that's the cruxus of any doctor's success. And counseling is an important point where you pick up a lot of things. So imagine while you're talking, the app can identify what are the risk factors and understand it. And it's easy when the patients can connect to their own age group. How long can a doctor give their time to a patient in an OPD? 10 minutes, 15 minutes, 30 minutes, an hour on the first consultation. But definitely you will not be able to have the stamina or the resistance in a busy OPD to spend 1 hour with each patient. So imagine, because most of them, I feel, is the recurrent question which comes up with the patient of like, what can I eat? What can I do? Can I climb a stairs? Can I eat a papaya? Can I do this? Can I go on a cycle ride? Can I take a flight? Can I do this? Most of the questions are a recurring question. I would say, I wouldn't mind saying even 95% of questions which are recurrent for every patient. So If there's an information where they can connect and they get an authenticated answer, like the FAQs that is available, and they can also connect to the same gestational age mothers, I think that would be an interesting thing where they're sharing important and authenticated information, which is a fact and not a myth. So they will not going to go exchange things where you have a doctor supervised and being in a part of their discussion. I think that will be very informative. And also they can see what can they do. If somebody is around 12 weeks of gestation, they can connect to an app and they know what should they be doing now. At a 12 weeks, they need to go for an NT scan, they need to go for a dual marker, or if they're at a high risk, they need to do an NIPT or an amniocentesis. At what gestation is best to do an amniocentesis? Are they taking their folic acid? It's time for them to take a tetanus shot. And when is their next scan scheduled, like an anomaly scan? So all these information coming up. And then they want to know if they want to travel somewhere. Is it safe for them? Can they travel? What to be eaten, what not to be eaten? All these things, if they can connect to their age group. So what a mother at the 7 months want and what a newly conceived mother, like initial 6 weeks, will be two different things. So if a 6-weeker to be mom can connect to all the 6-weekers across and get a lot of contacts, they share and they discuss and they are going to be reassured. Simple thing like nausea. It's easy for a doctor to reassure when they come back and say, oh, I have so much of nausea, I can't get up, I'm so sleepy, I'm not able to eat. They are so panicked, especially the first time moms to be. And equally, the father involvement I see is increasing day by day, and they're really panicked for their wives. And they are concerned, of course. So imagine you're going to be reassuring for a 2 minutes, 3 minutes, 4 minutes, you're going to give them injectables. And I don't think you're going to have patients more than that. And every time they come back, you're only going to say, look, this is common. You talk to somebody. Who is that somebody? If they can be a platform where they share and they get reassured that every mother goes through a nausea, vomiting, it's a physiological change. They need to be assured, and it's just a passing moment. Post the 3 months, all their symptoms are going to be better. And like I said, this platform where there are sensible mothers and they get the right information, facts, and not just the myths or a false information which goes to these groups. This is what I would want on a platform with the similar interest groups, what they are looking at. And whenever my mother goes into labor, I don't want them to be sleeping all the time. And then, the labor, I'm very keen on a normal delivery for all my first-time mothers. I have a very good success rate on vaginal births, even after cesarean. So I want these mothers to be up and about. I want them to be with their partners. I want them to be with their family. And I want them to be mobile and not just confined. Because you all will agree with me that monitoring during a labor is very important, because we can pick up fetal distress. We can pick up if there is a alteration in the CTGs happening. We know if the mother is comfortable, not comfortable. So this somebody needs to be constantly be there. And most of the mothers are going to be confined to bed. And I think with epidural also, it's very good. So imagine every time you need to monitor a fetal heart rate, which goes on every hourly or 2 hourly basis. And because of a pain, she wants to go out of the bed, but you're always pulling her back and putting her on the bed because you need to continue monitoring. So imagine a monitor where the patient can have it on her abdomen, which is actually monitoring the maternal vitals, monitoring the fetal heart rate. You're getting a CTG readings, the recording of the heartbeat, and the mother is ambulating. So she's walking, she's with her family, she's eating, she's talking to her relatives, talking to everybody. She wants to be there in the group that she wants to be there. And she's not just confined to her bed. She's sitting sometimes, she's walking around, she's doing whatever she likes to. And the monitoring is still continued, and you're not forcing her to just lie down on the bed. While the doctor or the sister also gets a recording just sitting at their nursing station, or while you run your busy OPD, you're still able to check the CTGs on your app or your mobile or your computer connected. And then you don't have to get up to go see her if the NST is good, or the sister doesn't have to come down to show you if the CTG is good, there's a distress. And you automatically get an alert on your mobile saying this baby is in distress, or the mother vitals are getting altered, while everybody is sitting in their own place, and only then you go and see that particular kind of a mother. Imagine this is going to be such a boon while you are doing a remote data access monitoring. And it is going to be paperless, where an intrapartum and immediate postpartum monitoring happens at your own comfort zone, and automated alerts are there, and it's with the standard protocols which is implemented in the apps that you're using. And also a cloud-based storage is very important, because we are all in the legal litigation world, where it is very important that you store the monitoring in your app and you store it in the medical record system. So you need to have a backup data for at least 10 years, because you don't know how the delivery process would have happened. Did the baby have a hypoxia for too very long time? So it's very important when you have an electronic medical records, and all these monitoring is also entered, because most of the EMR, I think, that is existing now do not speak to different machines which is available in the hospital, where the EMR is definitely used in the OPD by most of them, like I mentioned, at least in the metropolitan cities. And the monitoring happens in the labor room, where the NST machines are not speaking to your EMR. And so you still say you want a paperless OPD, but then when you go to your labor room and you're seeing you have a big file, because you're monitoring the NSTs and there are so many papers, and that goes to the MRD while your EMR stays separately. This is what exactly when I meant the machines needs to talk to each other, the applications needs to be talking to each other, and the data storage happens in one. So cloud storage is very important for every app, and every machine needs to speak to each other to have a data of that one particular patient in one combined format. So like I said, we should be progressing for a paperless labor monitoring software as well, where a complete labor monitoring software build-up is there, used by a professional to manage the labor very efficiently. It should generate time reminders and critical alerts to notify the user, and the dashboard gives access to all the patient details of where they are monitoring. So if they have a busy labor room of 10 people delivering, imagine you have to go and connect your machine to everybody. You monitor the fetal vitals, you monitor the mother's vitals, and then you miss out on a lot of vital informations, as well as you cannot be continuously monitoring, because there can be a deficiency in the machines that is available. If 10 people are all in labor, how many NSTs or a CTG any hospital can be having? Working in corporates, I know you cannot have more than 2 or 3. It's not that the patient load is not going to remain the same. So it doesn't make any sense if it's not a busy unit to have more than the 3 CTGs. And I think that is decent number to have. But then imagine you develop a software where you have one monitoring system, but you can connect more than 5 or 10 number of patients, and you are visualizing everybody's labor progress on one system, but all the 10 patients are simultaneously getting monitored. Isn't that what all an obstetrician would want? And this is what exactly I want. So what would I or my obstetrician friends would want to be seeing on a doctor's application? We want all the data to be seen on a remotely. That means I'm sitting in a busy OPD of mine, and my patients are still in the labor room waiting for us. And then we can see digital partograms remotely. We can see the live fetal heart rate going. You can see the uterine contraction graph sitting in the OPD. If she's delivered, postpartum monitoring also happens. The doctor can enter the notes while they're continuing to do their OPDs. Digital consents, if this is what we're talking about, paperless future, and we're talking about AI, I think everything needs to go digitally, where you have the digital consent and you have the digital case sheets, digital case accessibility alerts, and alarms are very important, which is very, very, very important. So on the dashboard, we need to have all the partograms, case sheets, intrapartum, postpartum analysis. And if you are referring out, imagine if this AI picks up, these app picks up, so many corporate hospitals can be attached to so many PHCs and remote monitoring. So we all know that there is so much of deficiency. There are so many medical colleges with so many seats, but the ratio in India for a doctor and the patient is inversely proportional. I would say one doctor will have to be there for like more than 2,000 or 3,000 population. So there are no doctors in the remote villages and in PHCs. There's a deficiency of doctors. Either they don't want to go or they're not there. So imagine these apps can monitor there while you have even an MBBS doctor sitting there and helping you out to do quickly, and you can transfer the patient on time. You can save so many maternal mortalities and infant mortalities. And you can also be attached with a lot of smaller nursing homes to our corporate hospitals, where they are also more confident where they know a qualified doctor or a better skilled doctor is monitoring their patients while they are also sitting there physically for their patients as well. And as a nursing station and the nurses in the labor room, I'm sure they will also be happy to sit in their nursing station and monitor 10 patients at a time, where they're seeing the digital pathogram of each patient, monitoring vitals of the mother and the baby is getting screened simultaneously. Like I said, digital case sheets, because imagine you're doing all digital and the case sheet in the labor room goes on a paper and goes to the MRD, and you have a litigation or forbidden, you have something else happening 5 years down the lane. Your EMR has no data of what happened to her in her labor room. So you'll have to dig into those things, and your NST prints are not going to be clearly visible after 5 or 6 years. So imagine all these things, data go into your app and it can stay forever. And this is why I said, going it to the cloud and connecting it to the cloud, machines being friendly to each other is very important. And imagine everything is entered here. There is a Bishop score. That means you are monitoring, you're doing a PV, you enter and see, is she a good candidate to help her progress into normal delivery? Is she a candidate for cesarean? You initially itself identify the risk factors or their favorability for going in for a normal delivery or for a cesarean, and accessibility and decision making becomes more important, and the alerts are there, and we can save a lot of time and complications as well. So one such company that I found was Janatri, and who had this devised care, where I always put up my ideas. I've been into innovations, I've been into digital platforms, I've been into innovative platforms on national and international level. So whenever I put out my ideas, like how as an obstetrician I want everything to be digitalized, understanding the trend that we are progressing to, I've met Janatri, and these are people who have worked on my ideas, and we as a combined team, we have worked. But of course, innovations can never be stopped. It can only get better day by day. A lot of people can pick up ideas from here and try and make things more better in reality for the doctors and the patients as well, and see what else can be done. If something is missing on this, like a fetal monitoring or a fetal kick is missing in this, you can add on to it, or you can come up with a better apps. And imagine, this was another idea that I've been having it, and I pitched it in one of the international platforms, of how we can have just a small digital monitoring system where the patients can use it at home and they don't have to come back to the hospital. And I think 5 years back when I spoke about it, I was not sure. I didn't get some people who were like-minded and wanted to think about this and making it as an innovative thing and coming up with an technology. And then I found them later. And COVID also helped, because a lot of patients don't want to come to the hospital. They themselves want to check if their baby is doing well. So that is how we've come up with another wearable fetal movement tracker, because it's very important, where patients do understand that, is my baby doing well? You can cut down a lot of visits of the patient to the hospital if they have any wearable device. It's not just this. You can think about so many things. You can yourself innovate things where they can think about, what is my baby's fetal heart rate? Because now everybody wants to know. I have patients, so many of them come in to the OPD daily basis or weekly. I see them, even if I tell them come back after 3 weeks, I would see them every 3 days. And I'm like, why are you here? They're like, oh my God, I didn't feel the movements today. I want to check if the baby's heartbeat is doing well. So imagine you have a wearable, you come up with a device where you know if the movement kick is happening, or it automatically captures. This one, I think, where you'll have to tap, come up with an idea where it automatically picks up. This is another idea that I want somebody to work on, where you don't have to tap, or you don't have to write down anywhere, or you don't have to come up with anything. An automatic tracker where it picks up, even if the mother is not felt, the device is going to say yes, and movement happened, and it gives out a beep. It's going to save a lot of people coming into the hospital. Me as a clinician, I want people who are going to come to the hospital when there is a need. And this is how I want to cut down unnecessary OPDs and unnecessary counseling to be done. I would rather put my time on people who really deserve your time and really look into high-risk cases. So imagine somebody, app or a device going to be there telling them you are doing good, your baby is doing good. And I think it saves a lot of time and financial burden for everybody. Moving on from the obstetrics to gynecology, like Dr. Bhardwaj said, I'm into robotics, and I think I would shout out to my previous institute, Narayana Health Hospitals, for all my experience in robotic surgery, where robotic surgery is going to be the future. It's not a competition for laparoscopy. Of course, laparoscopy is also doing very well, but then I'm in love with the robotic. But now imagine whatever was existing, like I am associated with Da Vinci for these surgeries at Narayana Health Hospitals, and I still continue to do my robotic surgery as a visiting surgeon at Narayana. So robotic is innovation, and it is so good for the patient and as well as the surgeon, because there is a magnification of 10 times compared to a laparoscope. 3D is now available in laparoscope as well. But then the ease of sitting and doing a surgery while you're doing a long surgeries of 4 or 6 hours, and robotic is used in every field. But me as a gynecologist, I have people come from different regions of the globe where they have huge fibroids, and they come back with the written tickets and they say, I want to go back in 4 days, 5 days. And I would say, let's do robotic surgery for you, because it's minimally invasive, faster recovery, pain threshold is much better, and it makes surgery more easier, even in complicated endometriosis and difficult surgeries. Now is the time for all of you to innovate more, because Da Vinci doesn't hold the patency anymore. And then so many more companies are coming up with robotic surgeries. See, like I said, you need to be attached with a doctor in whichever field. It doesn't have to be gynecology. It can be in cardiac surgery, urology, surgeons, and now we have next speaker, ENT. What do they want? What does the clinician want to make their life more easier, and in order to give a better care to the patients is what you'll have to think. So whenever an innovation comes or you are thinking about it, see, is it accessible, and making robotic surgery more affordable would be my interest on how can you reduce the costing, because each arm is very expensive. So how can you bring down the cost? How can you make the machine more sleeker? How can you use it in remote places? Because robotic surgeries are something that you can be using this in a remote place, because it operates by optic fibers. That is not yet done. Of course, in a very few cases it has been done, but imagine it's not done in rural setups, or you are not there. So you can be sitting in one center at a corporate hospital, like I mentioned, even be it the obstetric monitoring or the gynec surgeries, where you can give instructions to the surgeon sitting in a PHC or rural places or a smaller places, and then the surgery still happens and the patient gets the benefit of all the advanced technology, unlike just the metropolitan patients. So everybody should be getting benefited. So you'll have to come up with innovative ideas and put this on the digital platform where people can be using it more easily. Coming to infertility, follicular scans happen. This is where you can explore on a digital platform, because infertility patients, I feel, are going to be faithful. They would have done enough shopping, but once they decide this is the doctor I need to start my fertility treatment with, they come from distances. Trust me, I will say districts, and I have people who changed their home addresses from different states and countries to just get a baby. So imagine, the traffic, so much, COVID being regressing, travel and traffic has been one of the difficult things for people to reach on time. And even if my patient's getting a follicular scan done somewhere else and she wants to come back and show, imagine the digital platform is going to be there where she easily enters what is the marking, or you can upload the scan, which is done at a different area, and then that scan report can be seen by a clinician sitting in a different place altogether, and the instruction can go to the patient. You're saving the patient from not only traveling, but then the ease of accessibility of a doctor. The doctors themselves can improve their clientele in huge numbers if the patients don't have to travel. So follicular scanning, getting uploaded and getting their scans at their own comfortable place and still being accessible to the doctor is something very important. And when the doctor looks into this app, I would want to know which is the cycle. So imagine if you're doing it, you will be thinking like, oh, you can do a video consultation. What is wrong in that post follicular scan? But then in a busy OPD, like I mentioned, it's embarrassing to ask, which cycle is this? What medications did I give? Imagine once the report reaches and in one screen, I'm going to have which cycle is it? What medications did I give her? Which day of the cycle is it? how is the follicular measurements, and what is the plan made for her. Everything comes out. You are saving so much on the time. Time is money, time is patience, be it for the patient or for the doctor. I think it would be very good if all digital apps and digital platforms are going to be targeting both the clinician and the patient, and it's going to make patient friendly and doctor friendly. I think it's very important. Again, monitoring, like I said, the patients, when they're in a follicular tracking or a fertility treatment, they are going to come on almost daily basis. So imagine all these things can be done, and you have an app. And if imagine you have to take an injection on daily basis, a doctor is not comfortable, so they're going to say you have to come to the hospital, take the injection. So imagine the travel time that you're taking. Imagine this app also has somebody sitting in their locality and says, if I am in Electronic City, and if I'm a patient and my doctor is staying in Yeshwantpur, imagine the travel time that I'm going to take to reach my doctor. So I do a scan at Electronic City, I upload my reports, the doctor sees, and they are advising an injection to be taken. But I'm not confident. So what happens? If that app also says these are the nurses available in Electronic City who can come home and give you this injection. So imagine how much you can do for your patients, and you're actually making a difference to the society as well. And this is how I want you to get innovative and connect to the digital platforms where what do you want? Where are you getting from? It's a similar app based where in pregnancy as well. Now I want to go buy a diaper. So the app that you are going to make not only gives you information of what is happening to you, what are the symptoms that is common to you, what you should be doing at that phase, what is the medications the doctor has prescribed. You can chat with your doctors. You also know where to go and buy what you need. If you're advised just a cream for your stretch marks, where do I find this cream? So imagine the app will automatically tell you where are the places that you can go and find whatever you want. If somebody wants an anomaly scan, imagine where all in that area they can find an anomaly scan. So it's a similar, be it the gynecology, infertility, or an obstetrics. If the app can be patient friendly and doctor friendly and implement a lot of things, this is why I said you need to have a common person of what would they want. You also need to have a clinician of what are they looking at to make life easier. And that is when that app or a digital platform is going to be successful. So results and follow-up will also be there. There is no loss of patients, or the patient is not going to go shopping for another doctor. So everybody can retain their clientele as well. Screening is something that I'm always passionate about. We know that breast cancers and cervical cancers are increasing. I would love an app or a digital platform which sends out questionnaires, picking up a lot of people who are at high risk. Questionnaires come in, but then you fill up. You don't know what's happening. If there is somebody who's looking at this person could be a high risk, there is a shout out to that person, or there's a beep, or there's an alarm to that person that it's better they get their screening done, be it any cancers or be it anything. Confining to gynecology, they can be told that, look, I think it's time that you need to do a sonomammogram. I think it's important that you go get yourself a pap smear done. Like I say now, I think premarital sexual activity, multiple partners, all these things have become very common, and they are more prone for cervical cancer. So information also telling what is not good for them, using a contraception while they're accessing all these things or answering these questions, pop up clues coming for them is going to be very important, and alerting them that what could they be doing. Just a simple thing, when somebody is looking for a condom, telling them, look, if you're not using a condom, you could be more prone for sexually transmitted disease, or your partner can be, or your partner is looking for a condom. So, there can be a risk for cervical cancer. Just an alarm, somebody is going to alert. Unwanted pregnancies, all these things can be alerted and put on the app, and connecting all these devices. And reminding people when a sonogram needs to be done, when a pap smear needs to be done, who is eligible for an X-ray mammogram. As soon as the age comes up and their gender is feeded, they should be telling, like, these are the regular checks that you need to be done. This is how a digital platform is going to be successful. And also post-delivery or a perimenopausal women trying to use digital platforms or different apps, they go through a lot of stress incontinence, urge incontinence, post-delivery, again, the lax perineum. And we always, as a clinician, say, go ahead, do your Kegels exercise. This is how you describe the exercise. But are they doing it the right way? Kegels is nothing but then it's a pelvic floor strengthening exercise where they need to squeeze the muscles and do it over 45 or 50 times in a day. but are they doing it the right way? So imagine an app comes up and it tells them, and it picks up digitally if they're doing it the right way. And they also see on a digital platform, are they doing it the right way? Did they hold it for that number of seconds that they're instructed to? If they have a stress incontinence, urge incontinence, what is the kind of problem they have? If all these things can be done at the comfort of their home, imagine how life can be useful. Again, coming to screening of a diabetic mother, it's similar to the follicular scanning, like I mentioned, where the mother checks the sugar readings and they put it out on the app, which is attached with any clinician that is going to be there. The clinician can easily tell, or automatically the app tell them what is the dose of insulin that they need to be taking and how do they monitor, how frequently they alter. Along with that, if they get a cue saying that you need to cut down on your calories, I think it is better that you take this kind of a diet, and automatically all these things should be happening. I'm sure there are a lot of apps which just sends the sugar levels from the patient end and the doctor writes how much of insulin they need to be taking. But then imagine automatically there's a pop-up saying, this is what you need to eat. I think it's time for you to exercise, and this many minutes you have exercised. And if they have a tracker of steps, that is also implemented in the app, and they're all connected saying that this is the number of steps she's walked, and she can either reduce it or increase it. And all the apps talk to each other and they're connected to each other, and reminding them for a follow-up so that high-risk patients are not missed out. Wherever they are, they're still going to continue and they can be followed up. So please remember, any innovation is not an innovation. Any platform is not going to be successful if it is not going to be sustainable. It's not only sustainable, it should need to be affordable and accessible. So I want any innovation to be accessible and affordable, being with sustainable. Please remember, the growth will always be there. You should be able to scale up any innovation you come up, be it the digital platforms or the apps. But always remember, whatever you do it in moderation. With this note, I would like to thank you all for this lovely opportunity for me to speak. Thank you.
Thank you, Dr. Lavanya. There was a great presentation on what all we need to have. I'll be asking you questions on what all we do have actually right now. And I do have a few more questions for you, but we'll take it at the end of the talk, because
Sure.
Now I would like to invite Dr. Rajesh sir for his talk on technology and especially telemedicine in ENT. Sir, please, could you please share your screen? Dr. Rajesh?
Just a minute, I'm just sharing that.
Right, sir. So Dr. Rajesh, I have been associated with Dr. Rajesh for a long, long time. And in the ENT field, in the technology field, and within Telemedicine Society of India. And it's always been a pleasure talking to him. We just wait for his presentation now.
Yeah, you know, something happened here. We had put it up. Remember, the screen was being shared earlier.
Right, sir.
And just a minute.
No problem.
So in the meantime, I think I will thank Dr. Nilesh, because I know you will have a lot of apps and a lot of things, because I know you're so passionate about making digital platform a success, and you've been working on this for so many years that I remember, and we've connected on different platforms as well before, and it's wonderful to connect to you on a Sunday morning. And it's really a privilege for me that when I got your text and are you willing, I'm like, yeah, yes, we will do that. And
I remember, Dr. Lavanya. In fact, I was wanting to ask you, there was this app you had suggested in one of those hackathons years ago on sexual health and how they can have a social media kind of a social network.
Correct. Yes.
So did your team work on it later?
Yes, we did work. We have a patent on that, and post that a lot of split up and everybody went in different places. So that's still there. We can take it up offline and then do something. And I think these are all very important. And that is why I keep saying that, we can have a lot of questionnaire forms. It's not only about this, like sexual health education for people is also important, where people feel more easy to connect to somebody whom they want to. Because whenever I go and I give a talk on sexual health and all, we have more people and they say, I can't go and talk to this, to even a lot of doctors. And I think it's a mindset of the individual to change. I always say the caregivers also need to change their mindset, and you cannot be judging when you are going to get a clientele where when people are, there's no need to judge a person. They are free to do whatever they want to. We are here to tell them what is good and what is bad and how do they protect themselves. So they will still go ahead, and even whether you talk about sexually transmitted disease, they're still going to do whatever they want to. But educate them on the use of contraception, unwanted pregnancy. How do you prevent all these things? And I think that is where it is going to be better. And talking about all these things makes it more easier, and people are going to be aware. Because when they Google, they get a lot of information, which is good, bad, and not right. So you are just trying to stress them up. Instead, having a digital platforms and having questionnaires will really give them the facts and keep them more healthier, I would say. And a platform where they can discuss as well, the same peer groups.
Getting people together on any platform for any one specific thing has always been a good idea. I totally agree with that. The point I have is that, very often these innovations fail because they are not able to monetize the idea.
Correct. Yeah, I think that is one very, very, very important thing, and very important contribution that needs to be looked into. I think, financials will really make a lot of things. I think it doesn't take off as well.
Yeah, because I've seen so many doctors with wonderful ideas. So I had, the last time I went to AFMC, there was this naval surgeon who came over, and he had this idea of monitoring some deep sea sickness, some kind of a thing, and beautiful device. It could have saved a lot of lives. But the point was, how do we make money out of it? Because the subset of possible patients would be very, very less. Deep sea diving, kitne log karte hain? So these are the places where many of the innovations fail, which could be very good and life-saving, but it's business at the end of the day. So
at the end of the day, I think finances, vitamin M makes a lot of difference. So I think that's one area that you can explore, get all the innovators into one point, and then get the people with ideas and these things. Because I've seen being attached with a lot of entrepreneurs and companies who are ready to pitch in. Like you mentioned, just not the doctors alone, even in the public sector. I've had some, not anybody, he's not related to, he's not even a doctor, he's not an engineer, he's not an entrepreneur. He comes from a very rural area. And then because of some money that he had, he says, Madam, I want to make a mobile ambulance because, you city people are doing all digital. Can I have an ambulance with all the digital recording, and then I can connect to doctors in the bigger sectors? I think that's a wonderful idea. Then I told him, if you're looking at financial part, why don't you connect to companies? Yeah, now Dr. Bhardwaj is here, so I let him take over that.
Thank you so much. I'm sorry about that little glitch. The lights have gone off here, so I lost the connection for a while. Okay. Good afternoon. I'm Dr. Bhardwaj. My presentation today is on telemedicine and the role of telemedicine in ENT. We have been working together with the Telemedicine Society of India to try and work on some basic principles of telemedicine. And let me go through that as we have it currently, and including...
excuse me, sir. Could you go in the presentation mode for the slideshow?
Can you see that now?
Sir, top पे slideshow जो लिखा है उस पे एक बार.
Yes.
Slideshow, yeah, please.
Okay. So just to briefly tell you about by definition, what is telemedicine? So by definition, Telemedicine Society or telemedicine is the American Telemedicine Association defines telemedicine as the exchange of medical information on the health and education of patients and or healthcare providers via electronic means for the purpose of improving patient care. Historically, telemedicine became possible with Alexander Graham Bell's invention of the telephone. Even today, the telephone is still the medium of choice for practicing telemedicine. However, with the development of newer technology since 1960s, interest in telemedicine has increased. Two recent technological changes have led to an increase in interest in telemedicine. First is the simultaneous increase in availability and decrease in the cost of broadband communication. The second factor is the development of digital devices capable of capturing and transmitting images. So during the pandemic, if you remember, most of us were practicing telemedicine, and Dr. Nilesh was actually leading the whole exercise and enterprise, because Practo offered us actually a wonderful telemedicine platform. And we can see obviously the advantages of telemedicine. The current status is, and this now we talk specifically to otolaryngology, and this is a research that was carried on by the army people, the defense persons for the veterans in the United States. 62% of otolaryngology encounters would likely be eligible for telemedicine. Patients with inner and middle ear problems were more likely eligible for telemedicine, while patients with problems affecting larynx and external ear were least likely. Nearly 90% of veterans drove more than 1 hour round trip for services. Understanding which otolaryngology problem types are more frequently eligible for telemedicine may assist those who are planning to implement a telemedicine program. If a specialized procedure was necessary to reach a diagnosis, the diagnosis was considered ineligible for telemedicine. We have then the Telemedicine Society of India, which actually brought down guidelines last year. And these guidelines were a shot in the arm. If you remember, there was an adverse order by a high court, which said that telemedicine there was some strictures passed against doctors for doing telemedicine. But then the Telemedicine Society of India brought down very well laid out guidelines, and they established the framework under which we can now operate. They came out at the right time at the start of the pandemic and helped us get robust telemedicine platforms ready. However, the observation to the name telemedicine is maybe particularly now, once we go into 5G, once we go into robotics, and once we get into the metaverse, it is possible that telemedicine may be a narrow definition, and remote medicine may be a more appropriate terminology to use in this context. So as far as Telemedicine Society of India is concerned, the guidelines very clearly and strictly lay out that both must be known, that the doctor and patient must be known to each other. If you see today, a patient can walk into you anonymously, can write any name and come across. Nobody asks for a document check or a document ID. I mean, I could go into any clinic, write any name, have myself seen and come back without having any checkup done to find out who am I really. But the Telemedicine Society of India for remote medicine or for telemedicine specifically prohibits us from doing this unless and until the patient identifies himself or herself with a unique identity which is provided by the Government of India. We cannot proceed with the telemedicine protocol. So e-consult and the virtual clinic, this is what telemedicine is promising to give us. And the essential requirements for this would be a good broadband connection and a device for image capturing. And as Dr. Lavanya has also so nicely brought out, what a wonderful lecture that was. It's such a wonderful talk that we listened to, and it brought out so many things so clearly. So basically, we have to have a good broadband connection and a device that can capture image in a remote setting. And this is already happening in a large areas. If you remember why this is so necessary for India is because at the start of the pandemic, the one thing which was boringly being repeated in every national and international newspaper or media was woefully inadequate health infrastructure of India, that India is vulnerable and India's population does not have access to good healthcare. So for a country where our health infrastructure is inadequate, telemedicine is that one game changer where with limited resources, we can reach a larger number of people and satisfy them and take care of them in a more significant manner by a fewer number of healthcare professionals sitting in remote locations. So for India, at least, telemedicine is a wonderful platform, keeping in mind that we are a resource, particularly a healthcare resource deficient country. So key parameters for judging of our virtual clinic parameters would be image adequacy, diagnostic concordance, patient satisfaction, and doctor satisfaction. These are the 4 things we are looking for as far as the telemedical medicine platform is concerned during the process of a consultation. Artificial intelligence unique ability lies in using computational algorithms in analyzing vast amounts of data to make clinically usable output of it. We have been reading, there are media reports and other science journals that are telling us, and there are predictions that 30% of human jobs will go out because robots and artificial intelligence will take over and humans will no longer be needed, particularly for boringly repetitive jobs, accountants, cashiers. It's possible that robots will take over and we may not even require humans for that. But that's still a far way off because artificial intelligence, there are a lot of things with artificial intelligence that we need to sort out, settle, and bring in into before it can come in and actually establish itself in the mainstream in the domain of clinical medicine. Artificial intelligence can determine potential diagnosis and decide on the best treatment plan for a specific patient. Special applications in neurotology and audiology, including testing for balance disorders. AI can help predict which patients are more likely to have post-operative complications, permitting early interventions in these cases. Now, machine learning is just a step up from artificial intelligence. Machine learning, and you have all your smartphones actually are enabled with machine learning. And you will see that because there are certain things that happen automatically on your phone, which is a dual application of artificial intelligence along with machine learning. Machine learning is a scientific study of algorithms and statistical models that computer systems use to perform a specific task without using explicit instructions, relying on patterns and inference instead. It is seen as a subset of artificial intelligence. So telemedicine and ENT, how does artificial intelligence help us in the ENT domain? In otology, AI technologies are used in determining the prognosis of sudden sensory neural hearing losses in otology. See, anywhere where there is a lot of variables in data, whenever there are a lot of variables in data, artificial intelligence will help us because the human mind can only compute so many variations after which it falls short. Whereas a properly enabled, AI-enabled algorithm can compute hundreds of data and bring together a result, which is probably a little more acceptable than what a human mind can comprehend. In the imaging of endolymphatic hydrops, we use AI technologies and in identifying phenotypes of hearing loss. In laryngology, T1A glottic cancers and other pathologies of vocal cords can be diagnosed with almost 100% accuracy when AI programs are used together with voice analysis and video stroboscopy images. In rhinology, diagnosis of sinusitis and detection of sinus pathologies. And particularly the role of remote medicine and the role of artificial intelligence as well as deep learning specifically came in radiology. So it was actually predicted at one time that machines will take over the role of radiologists, and there will be a time in the next 3 to 5 years that radiologists may no longer be required because deep learning, artificial intelligence, machine learning, and the algorithms, deep-seated algorithms that we built in for reading radiographs and CT scans and MRIs will do away with the need for radiologists, but apart from interventional radiologists, but that has not yet happened. It is still a long way off, and it is feasible, it is possible, it may never happen. The intelligence systems built on machine learning algorithms have the capability to learn from past experience or historical data. Machine learning applications provide results on the basis of past experience. Specific applications of machine learning are image recognition, speech recognition, and medical diagnosis, used for the analysis of clinical parameters and their combination for the prognosis, example, prediction of disease progression for extraction of medical knowledge, for the outcome research for therapy, planning, and patient monitoring. So, video teleconferencing. In real time or VTC, the consultant and requesting physicians see the patient at the same time. In store and forward, the patient is seen asynchronously. Store and forward would be emails, WhatsApp messages, chat boxes, where a patient is sending you a message, you're responding to that message. But in a VTC or a video teleconferencing situation, you are actually virtually sitting together in the same setting. And the beauty of this application will become much more clear when we have virtual reality and when the meta universe that is right around the corner, it has come to be in certain persons, certain establishments, certain institutions are using it. As and when the metaverse gets launched, the video teleconferencing will become like a virtual treat because you will be sitting in instead of going to the waiting room of the doctor, you will be sitting in a 3D virtually enhanced environment, and it will feel as close to the real thing as possible once Meta is properly launched, once the Oculus glasses become functional, and once this whole process that they're spending billions of dollars on gets properly established. So store and forward has been embraced mostly by those specialties that rely in some part on pattern and image recognition being predominantly visual, such as pathology, dermatology, and radiology. So we can see that in pathology, it's very easy for a pathologist to take the slide home and they need a microscope and visualize the slide. They don't need to be physically present in any particular location. In dermatology, apart from palpating the lesion, if the lesion is a surface lesion and the dermatologist just needs to see the scope and the size and the color of, and the location of the lesion, many skin disease diagnoses can be made in a store and forward format. The VTC format has progressed more in specialties requiring significant physician-patient dialogue or interaction, such as psychiatry and intensive care. So what happens in ENT? Suppose there is a young mother with 2 or 3 children in the house who are aged between 2 and maybe 6 years of age. And she's bothered because there is a family history of ear disease, and every second month a child has some ear problem or the other. Well, this is where telemedicine comes in the palm of your hand. There is a device that is available. She can connect this to the smartphone. The device will take pictures. She can send these pictures to the pediatrician or to the concerned ENT specialist or otolaryngologist. The otolaryngologist can take a look at these pictures, advise some kind of medication. And this not only helps the mother because she's got children to take care of at home, she's got a job that she's taking care of, and there is traffic, there is waiting in the doctor's clinic. So all of that can be subvented by just taking this picture, sending it to an otolaryngologist, having the doctor see and prescribe medication. And the one thing we have seen that has helped us in this format is that it has prevented misuse of antibiotics for simple ear infections where an antibiotic was not necessary in the first place. Telemedicine ENT, several vendors now manufacture digital otoscopes and rhinoscopes that can be connected to a telehealth platform to collect and send or store images. A few of these devices can attach to an iPhone. Teleaudiology applications allow hearing tests and hearing aid programming to be done at a distance. In fact, the WHO itself has brought out a hearing app where from the comfort of your home, you can attach headphones to the app and determine for yourself whether you have a hearing loss or not, just on the basis of the WHO app. Use artificial intelligence to determine potential diagnosis and decide on the best treatment plan for a specific patient. So this is how, as I was saying, talking about our neurootology. So we have a vertigo clinic. In the vertigo clinic, we actually have remote monitoring of what the results over here are showing in our clinic. And this is how the whole system works. The patient and the specialist. And then at the back end, through cloud computing, we have a super specialist doctor, where actually there is a senior ENT specialist who deals with nothing else but vertigo, and a senior neurophysician who also specializes in management of vertigo. So what we do is the patient comes to the specialist doctor, for instance, comes to me at my clinic. I have this virtually enabled setup over here with a technician who does all the tests. The test results are directly fed in via cloud computing at the back end. And at the back end, the super specialist doctor, who is a trained ENT specialist in vertigo, and a neurophysician give a diagnosis. Once a diagnosis is given, we have an integrated mobile app. The integrated mobile app will tell the patient what was your diagnosis, tells the patient if there is any medication required, and also, if you see, schedules exercises for the patient. So various rehabilitation programs that we run for vestibular neuronitis, vestibulopathies, and otolith disorders, they have through the app exercises that are run where videos are shown to them week on week with gradually increasing complexity so that their problem is taken care of from the comfort of their home. And that is the application of telemedicine in ENT as far as management of vertigo is concerned. The other therapies that we can safely use and are using actually are speech therapy and swallow therapy, apart from vertigo exercises. What are the problems with telemedicine? Security and data confidentiality. That is something we've been talking about forever. And that is something that definitely needs to be addressed. For instance, and this is in the hospital scenario. In the hospital scenario, you have an electronic data HIS system that is working. And in that interface, any patient's detail is available to any other doctor to be used as long as you have a login. Now, we had worked on this in various other hospitals where we found particularly the 2-3 things that we didn't want access for all doctors to were records related to mental health, because obviously mental health is something they don't want to talk about and they don't want to come out in the open. Records related to your gynecological and obstetric history. We do not want anybody to come out and say whether somebody came and had a procedure done. So there is definitely data and confidentiality related to telemedicine, because if you have a log, if there is a system, you're using a system or a platform, the platform has a user ID and a login. As soon as you log in, it is possible that you will have details of everybody else who is on that system, and that may lead to breach of data as well as security and confidentiality and privacy issues. It doesn't, the second discrimination or problem is it doesn't allow for a face-to-face examination, nor can a physician perform procedures such as biopsies or endoscopies. It limits interaction to simple history acquisition and taking a superficial topical examination, restricting the depth of information that a physician can obtain. Data bias. Now, this is something we've been dealing with. Artificial intelligence is as good as the human who's feeding artificial intelligence. And we are already seeing in artificial intelligence that there are the bias that is built in by the person feeding in the artificial intelligence will lead to a bias in the system, will lead to a bias in the diagnosis, as well as in collection of that health data that we are particularly interested in. And more importantly, in a medical legal way, as Dr. Lavanya was also trying to bring out the medical legal aspects of the nature of the work that we do nowadays is so highly, there's so much of litigation that goes on. So suppose I'm doing testing for vertigo and I put in a caloric test. I'm doing a caloric test. And in the caloric test, when the air goes into the external ear, causes a minor perforation in the tympanic membrane. Now, who is going to take responsibility for this perforation when the patient says, I came in all right to you, I came in for vertigo, you haven't treated my vertigo, at the same time you've caused a perforation in my eardrum? Will that technician take the responsibility? Will the doctor whose clinic in which this test is being carried out take the responsibility? Will the artificial intelligence or the algorithm that created this take the responsibility? Or will the person who produced this particular device and has asked for a patent and has been patent in that person's name and he's earning out of that patent, will that person be responsible for this damage to the patient? So these are gray areas that we definitely need to address, because we could somewhere down the line get into trouble, because who is to blame if an AI system fails? And what we are waiting for now is 5G. And as Dr. Lavanya is a very keen robotic surgeon, and she's, I'm sure, very, very keenly waiting for 5G, because this is what 5G is going to do for us. Quickly transmit large imaging files, expand telemedicine, improve AR, VR, and spatial computing, reliable real-time remote monitoring, and artificial intelligence. 5G will help enable the speed and exponential computing at the edge that will encourage more widespread adoption. It will support healthcare IT infrastructure as remote clinicians and telemedicine extend the organization's reach beyond the hospital premises. With 5G, language translators can video conference with the patient and doctor at the network edge with low latency. So basically now we are coming to augmented reality and virtual reality. And as I said briefly in the beginning of the presentation, when Meta comes, it's not if, when, because, well, there is so much of money being spent, not just by Facebook, but also now by Google, Apple, as well as Microsoft on virtual reality and augmented reality, that with these large players, the largest player, global technology partners that we use for practically 99% of our daily needs, if they're all investing heavily into the metaverse, into a virtual reality world, it will be there for us in the very near future. So virtual reality and augmented reality, we will have to learn to deal with it. It will definitely offer the patient and the clinician a much more tactile, sensory experience as compared to what was earlier, because the virtual reality experience will kick in, and there will be, as they are progressing towards it, there will be haptic control. The haptic will give you some kind of a touch and feel. So you will have a touch and feel experience with haptic. So basically 5G and the metaverse will convert telemedicine into a totally new realm altogether. 5G will eventually open a vista of opportunity to use augmented reality and virtual reality to care for patients and to train clinicians. reduce pain or anxiety for certain hospice patients by providing calm, distracting content via 5G enabled AR and VR. This is already happening. Today morning, I was reading today morning's newspaper, the Financial Express, and it talks about certain hospital chains are already in touch with technology partners who are enhancing their virtual reality programs and platforms, and they will now be using that for patient counseling before surgery. So the first application they are going to use the metaverse in, or the virtual reality, is in pre-surgical counseling of patients. And they will be sitting across in a virtual environment across from each other, and every question that they need to ask will be asked and answered virtually. 5G powered AR VR has the potential to help enable doctors, nurses, interns, and staff to more aptly visualize procedures in an engaging learning by doing practice that will enhance their education. 5G will support the connection of smartphones and mobile apps, cloud services, devices, sensors, machines, and systems that can be used to power big data analytics. For instance, the smart car of the future will work on 5G. It will have cameras. So the driverless car, if a car can drive on your roads without a driver using 5G connectivity, you can imagine the extension of this application into the healthcare field. What are the shortcomings? The performance of robotic telesurgery largely depends on network performance in terms of latency, jitter, and packet loss, especially when telesurgical system is equipped with haptic feedback. This imposes significant challenges to design a reliable and secure but cost-effective communication solution. Rural areas could especially benefit from telemedicine, but 5G is most efficiently deployed in high-density areas because 5G base stations need to be in close proximity to one another as compared with previous generation base stations. One option for rural areas is to deploy frequency-divided spectrum, 5G, which has low latency but less capacity than standard 5G. And for all those who are in a private medical practice, the elephant in the room obviously will be reimbursement, because Indian insurance companies do not pay for OPD consultations. Quite often, patients send messages to you with the hope that those messages will be answered. They send you detailed emails along with detailed CT scan pictures and old reports from other doctors and expect an answer immediately. So this is what we call in medical terminology and in financial terminology a loss leader. A loss leader is where you attend to something at a loss with the hope that maybe somewhere down the line, some reimbursement will be happening, either the patient consenting for a procedure and comes and gets a procedure done, or gets a surgery done subsequently with you. So for the private medical setup, reimbursement is the elephant in the room. Till sturdy reimbursement models are not built into the system acceptable by third-party players, the private sector will be late to adopt and benefit from the full benefit of telemedicine. Human intelligence, it's all right. And this is what the future we are looking at. Maybe in the future, will a doctor actually pop out of your TV screen and treat a patient? Thank you so much. This was my presentation. Dr. Nilesh, anything else that we need to address?
Sir, I think you have addressed quite a few things, but the first question I have for you is the part on acceptance. How do you see this acceptance amongst doctors being there for telemedicine or remote medicine, as you would like to call it?
See, what is going to happen is you cannot get away from technology. 7 years ago, did anybody think that? Did you even know the meaning of an app? And nowadays our world is run by apps. 7 years ago, most of us had no idea what an app would be. And when I learned that the Apple smartphone has got apps in it, I used to wonder, what is an app? What is an app going to do? Do I need to download this app or not? But now our lives, from booking railway tickets to booking flights to ordering a meal to getting your milk in the morning to seeking an appointment through Practo with a doctor, everything is done to your phone and through an app. So that whenever technology enhances convenience, you cannot beat it. People will have to adopt it.
I agree with you, sir. But that also brings the second question into play, which you also touched upon. Hasn't this convenience actually spoiled the patients, because they accept, they want to chat with you, or if they have started a teleconsult with you, they want to answer within 10 minutes, even at night. 11 p.m., 1 a.m., they want answers within a few minutes. So, इस पे भी कुछ करना चाहिए ना?
Yeah, Dr. Nilesh, I'll tell you something. First of all, there has always been this dichotomy or disconnect. Doctors talk about patients in a manner, patients as if they are from outer space. And patients, and I'm sure the patients at their end talk about doctors as if doctors come from some other alien planet. So we are all human. We are together in this. We are all human. We go through the same experiences. We are all across living in the same society. So this pretty much the doctor-patient disconnect actually is not, it's virtual in the sense it doesn't really exist. My experience, of course, and it also depends on the kind of work that you do, in the environment in which you're working, in the specialty in which you are, and the clientele that you have. I think at the end of the day, if you respect the patients and are willing to listen to what they are saying, by and large, I have found more than 99% of times, their requests are usually reasonable. And they only will bother you if there is a child has put a foreign body in the nose, or there is so much pain that the child is crying and not sleeping. It's only in dire emergencies that they really try to get across you in a manner that is emergent. Otherwise, they are generally happy to wait. And of course, there will be that 1% who will not. But then what can you do? That's human, right?
Right, that's right. The reason I asked this because we at Practo have been facing this a lot when patients want to chat at 2 a.m. and they get angry if they don't get an answer by 2:10 a.m. And there is highly unreasonable request on the part of the patients.
So I'll give you my experience of that. So that was the video calling platform. The video calling platform was, so a patient has taken an appointment for a video consult for 4:45. Now, as we were also highlighting and bringing out in the presentation, everything depends upon your data. And this happened right now in a place in the country where I may lose electricity maybe once or twice a year, but at this most crucial time when I'm to make a presentation, when my slides are uploaded, I lose electricity. Just for a fraction of a minute, but everything goes haywire. So similarly, and some of these people are in remote areas where they don't have so much of data. It is possible they try to connect with you, and the time they don't connect when you have given them time. When you try to connect with them, they don't have data there, or they don't have access to internet facilities. So there is that mismatch of data when you don't have robust data at either end. There will be this problem where your appointment scheduling will go haywire, and that can sometimes be a problem.
Right, sir. Dr. Lavanya, I'll carry on this question to you also. I know we had a talk and you said that you were doing a lot of teleconsults when you were with Narayana. I'm talking about the pandemic time. But we did some data crunching in Practo, and we found that gynecology was always amongst the top, ENT too, but gynecology was always among the top 2 branches to be consulted during the pandemic. Maybe you could shed some light on why gynecology, because we can understand ENT, pulmonology, GPs having a good teleconsult practice during pandemic because of the pandemic itself. But gynecology also shot up hugely teleconsults during the pandemic. Any thoughts on that?
Yes, Dr. Nilesh, but I would like to differ with Dr. Bhardwaj when he said only 1% do not stick to their timelines. And I think we will move him to gynecology and he'll realize it's 95% or 98% not sticking to the decent hours. But I think mostly it's just because the emergencies crop up, or it's the anxiety of the patient which makes them feel that they want to connect to their doctor immediately. This is exactly why I was telling, while you have a digital platform, you also connect a similar kind of people to them where they themselves get reassured saying that, yes, this is okay, this is not okay. In gynecology, I think it topped because they didn't want to come to the hospital because it's a COVID time, and they don't want to risk because every time it's an obstetrics case, you're dealing with 2 lives. So that's one of the precious moments of the life where they do not want to be going to the hospital in the pandemic. And like I said, though the COVID is receding, we still see a lot of teleconsultations, video consultations going only more and more in number. And every day we have more requests of people asking to increase the time slot for video consultation. So I think this is going to be here. It's to be staying. I think it's just basically more of a anxiety situation that they want to get it clarified at the right time.
There's a question from Dr. Mohan over here. He has a doubt. So when you say that patients can get together and help each other out, these days, would it confuse the patients or would it have some privacy concerns also?
Yes, exactly. See, privacy concern, you're connecting. So you are connecting there or you're going into that group with your willingness. Correct. So there's no question of privacy because you are in a group. You are already Googling a lot of things and then you're getting your information there. And it's like I said, it's like if you're pregnant for the first mother, they have their own group. Because the concern of a second time mother will totally be different from a concern of a first time mother. So similar groups where it is watched out or it is supervised, I would say. This is why exactly I said they get the right information so that they can reassure, because I really have patients who come in every second day, third day complaining about their nausea, vomiting, and then you have to just, it's the TLC which matters, the tender loving care, and just tell her like, it's okay. That's all they need. But how many of us or anybody has so much time to see them every second day and just tell the same thing? So when it comes in, because most of them are in nuclear families, unlike before they were reassured by their moms or in-laws or their sister-in-law sitting there and saying it's all right. But now it's mostly a nuclear families. So connecting, and I think if they can talk to their peer groups on the same stage, like a 5th month lady would be anxious of why I'm not able to feel the movement. So somebody can always, and like Dr. Bhardwaj said, you can be getting a mail or a text saying that, I'm 5th month, I'm not able to perceive a movement. Is this all right or not? We really have people come in to check, is my baby's heartbeat all right? Because I'm not feeling movements. So somebody saying like, look, I know it's going to happen only at 20, 22 weeks. And it's not just the same group of people receiving the information also matters. Like, yes, every first time mothers get to know, though you would have told them on the first visit. I have a chart which goes to the patient file, where on the first visit, I really spend a lot of time telling them your movement will happen only after 5th month. Your position of sleeping will be spoken to you only after 5th month. Your 2 doses of TT, the first one will be given after 3rd month. So everything will be explained, but it is not going to be there in their mind. And they still end up asking at the 4th month, why am I not feeling the movements? So when they're in that peer group, those questions get answered. And they also get a regular text. Like I said, it's supervised and say, now if you're at 5th month, you're only about 20 weeks, you will be able to perceive a fetal movement. So nausea is very common. So on a regular texting messages, which goes in the group as well, by somebody who's supervising the whole conversation. So all these things can make things more easier for everybody.
Dr. Nilesh, what she's saying is right. So first of all, the privacy part is pretty much built in because as she's saying, they are volunteering to become part of that group. So for instance, self-help groups, if you start off with the most famous one, which is Alcoholics Anonymous, it's a self-help support group. Self-help support groups have stood the test of time. And in a situation like this, for instance, in ENT, we use them for tinnitus management. Tinnitus can be a very, very troublesome and a very dreadful kind of a problem to have, where usually no known cause is there and patients have to learn to deal with it. And treatment will sometimes be very difficult. So the self-help group monitored, as Dr. Lavanya is saying, the conversation is supervised by a healthcare professional and let them deal with it on their own. You'll be all right. Don't worry. Theek ho jayega. Mera bhi theek ho gaya tha. So that kind of self-help group, support group actually helps in the long run.
I totally agree, sir. Dr. Lavanya, you put me in this future world where I was just imagining what you were saying about those labor monitoring software where, I haven't entered a gynae ward for a long, long time. But I was just imagining, having 10 to 15 pregnant ladies with all this monitoring devices, non-invasive ones, and you have just one nurse or a doctor monitoring all of them. So you had a long list of things which can be done. What is being done right now? Do we have anything around that, around the labor monitoring software right now?
Yes. So I pitched in this idea sometime in one of the hackathons, and then I had a company come up saying that we've been working on a similar basis, would you like to be attached? This was like almost 3-4 years back, and they had something which looked like a radio kind of a thing, and in a very primitive stage, which they wanted to work on the similar lines of not being patient being confined to the bed. So while we sat and worked over, I put in one of the slides with Care and Janatri, they're the company that I'm attached with. I'm doing this because I believe that anything that you speak out on a platform and give it out to the society to be using, you need to always evaluate it, validate it, and go through an ethical committee. So we're doing a study with them right now, though I've been a part of their clinical proctoring and principal investigator. So we're taking a study which is with the conventional NSTs, which is there in almost every hospital that I would know of. And this is a new machine which will be out very soon, where there are studies at AIMS going on, be it Narayana. I'm still associated with that, and this is how it is going. So these softwares are done, and it has been quite easy. There are some smaller things where it can be still be changed, and this is why I was telling, if there are any more innovators, they can work a little more keen on that and make it much more better.
Oh yeah, I think you have given us dozens of ideas to work upon. Just us to work on it.
Yes.
Another thing which really wowed me was those fetal movement trackers. I mean, this is such a basic thing to have. I mean, they should be everywhere, in my opinion. So, are they easily available in the market? Are they being used right now, or just the idea process?
This is to be launched. This was again one of my ideas where I pitched in, and long back, I was thinking, why should, because this is all on a clinical perspective where you really want to cut down. When I was in my previous Institute of Narayana, my OPD would go, it's a corporate hospital, and imagine I'm sitting and seeing there 100 to 110 patients. And, you are hardly spending any time, though you have a huge team working on that. So that's when I used to think, why is it somebody coming every third day to say, I can't feel the movement? And then I have to invariably, though I check the heartbeat, I'll tell her, go do the scan and come. And this is when I was thinking, if the mothers, it's just that, like I said, most of them needs to be reassured where you're spending time, unlike in a typical corporate where even 30, 40 numbers is a huge number. So there it's a different ball game altogether. And mostly most of them see good numbers. If you have something at home, you can cut down. And I think the pandemic has helped to come up with such innovations where the tracker can be used. And this one, the existing one that I'm working on, you have to tap every time. So you get a number of how it is done. Imagine you can automatically do it. This is what I was trying to tell them. And this is why I'm trying to pitch in here as well. It automatically picks up the movement and it's automatically recorded. And the mother is like, because we have people who come back and say, I think, the intensity is not so much. You told me you need to have 15 or 20 movements. I think I didn't have it. But when you take a NST tracing, you see that the heartbeat is good, the NST is good. And there, when she comes to hospital, doctor, while I was sitting to waiting to see you, I felt 5 movements. I'm fine now. Imagine all the strain that she took to come to the hospital from distance, traveling or doing a video consultation. I can't assure her on a video consultation telling that it's okay. I have to call her back for a monitoring of the fetal heart, or I have to tell her, please go get a scan done and then you upload your reports. Imagine if there's a tracker like this, which can help her, like, yes, look, your baby is moving. It's just that we have to work on the sensitivity and the specificity of the machine that comes up.
Right. Dr. Rajesh, I think you're here.
Yes.
Yeah. Dr. Rajesh, I was wondering about how useful and how common is robotic surgeries in ENT?
So, Dr. Nilesh, for the previous Telemedicine Society webinar, their annual conference actually, their annual conference was held remotely. And I and my classmate, my batchmate from FMC, Dr. Bhardwaj, who's at Bombay doing robotic surgery. And we actually had robotic surgery was part of our the discussion on the webinar. And robotic surgery, definitely the applications of robotic surgery as far as remote operating is concerned is huge. And again, as I mentioned in the presentation, the presence of 5G will definitely enable and help robotic surgery. And also, we do not know as yet because everybody is very, very unclear about how the meta system or the meta universe is going to work. But there would be applications of robotic surgery coming up. They will have to build in robust systems and platforms to enable you to do it safely.
Right. So, connected question on this. Remote robotic surgeries, are there any legal points involved right now? Is it been legally clarified that we can do remote robotic surgeries right now?
See, again, these are gray areas. For instance, the legal requirement of a doctor in India to operate is that he or she must have a postgraduate degree that allows them to operate. And if you have a registration with the Medical Council of India, that is enough for the rest of the country. However, we have seen and we are witness to the fact that state medical councils keep muscling in because for some political benefit, some financial benefit. So they will force you to register themselves in state medical councils. The legality of state medical councils has never been clearly built in. To my mind, it would be enough if you have a Medical Council of India degree that is recognized, your graduate as well as your postgraduate degree, there should be no legal or ethical impediment in your operating anywhere in the country.
Right. Dr. Lavanya, I know many of our audience would be interested in getting trained in robotic surgeries. And I know you have been training people in robotic surgeries. So what's the process? How does a gynecologist get trained in robotic surgery?
So now I think there is MCH available, there is fellowships available for robotic surgery training as well. So that can be done. I'm a listed proctor for robotic surgery. So you have to get trained with the machines. So you have to register with the company. And then depends, there are a lot of proctors in different states as well. So they will see which is the most feasible for them and they get attached to that.
Oh, okay. So I'll just take a last one or two questions. So where do you see gynecology and obs, obviously, in 3 years from now? What technologies do you believe will be there in the market in 3 years, used by everyone?
Definitely home monitoring devices will be it obstetrics, gynecology. I think home monitoring devices is way ahead, and that will be the dictum for the day. With the digital platforms, video consultations and teleconsultations, I think is here to stay.
Same question to you, Dr. Rajesh. 3 साल में कहाँ पहुँचेंगे हम लोग? How well entrenched will be technologies in ENT practice in 3 years?
Dr. Rajesh, the problem is in the human touch and feel experience, the tactile experience, the sensory experience of, we are so used to going to that boring doctor's chamber, waiting room, read all those old magazines and newspapers, wait our turn, go in, see the doctor, talk to him, come back in 5 minutes. Some of that is so well entrenched in our system just now that it will be to some extent an uphill task to translate that or to convert or to transform into a virtual environment. There are enhancers. So as I said, data is an enhancer, technology is an enhancer. The final hurdle that we will have to cross is our mental enhancement. That is, we will have to mentally be happy with a virtual consultation. And as we have seen, and as this discussion also has shown us so clearly, many areas allow themselves to be consulted virtually. It saves time, it saves effort, it saves energy. It's an overall a more pleasant experience to sit in the comfort of your home and consult your favorite doctor, whoever it may be. It doesn't have to be in your town anymore. It doesn't even have to be in your country. So look at the multiple advantages of this platform and this forum. I'm sure looking at the multiple advantages, it will be adopted. The two uncertainties I can see right now are our adoption of 5G and how soon that can be enabled. And secondly, how soon we learn to embrace the metaverse.
Thank you, sir. So I think it's been a wonderful Sunday morning spent for me. And I won't keep you too long. Thank you, Dr. Lavanya, for sparing the time for this. And it was a pleasure meeting you again after such a long time.
Thank you.
And thank you, Dr. Rajesh. Pleasure as always.
Thank you.
Thank the audience for attending this. And before we go, let me tell you that we're getting a lot of things from doctors saying it's a very good topic and they really enjoyed the talk. So thank you all once again. Have a great day ahead. Bye-bye.
Thank you so much. Thank you all.
Thank you.